as an emergency room follow-up. And I am a minimally invasive surgeon and I focus on endometriosis and fibroids. And I really enjoy helping women to be able to take back control of their lives. As shared, I have done two fellowships, but I've really tailored my practice to focus on care for women with endometriosis and fibroids. So she just happened to land herself in the right place. What ended up happening is we completed her evaluation. So after a thorough history and physical exam, did an ultrasound in my office, followed by an MRI. Repeated ultrasound because the style of ultrasound that I do is different than what she had received before. And I gave her the diagnosis of presumed endometriosis. And I'll talk a little bit more about that because if I were to see her now, I would write different words in her chart. Also, chronic pelvic pain and pelvic floor dysfunction. She had surgery. It was a laparoscopic surgery to excise endometriosis, which was found to be stage 2. Also, an ovarian cyst and a cystoscopy, so looking inside her bladder with a camera to look for any other issues. In the time after her surgery, she had an IUD placed for birth control and because of midline pelvic pain that was concerning for adenomyosis. The most important thing is that she had relief of these symptoms that she had been having for more than a decade. She was no longer having pain with her periods. Her thigh pain went away. Her pelvic pain throughout the month went away, and she was no longer feeling bloated. Let's take it back a little bit to what endometriosis is. And I'm probably speaking to a lot of people who are very familiar with endometriosis, but there are new people who are getting this message all the time. So, endometriosis is a chronic systemic inflammatory condition. And it's one where tissue that's somewhat similar to the inside part of the uterus is growing in other places. It can really be anywhere in the abdomen and pelvis, and it can even be found beyond, like in the chest, around the lungs, or in the belly button. The hallmarks of endometriosis are pain and pelvic symptoms like painful periods, pain with sex, infertility, heavy bleeding. But endometriosis is not just like a women's health disease. It's not just a gynecologic condition, and it can cause symptoms in many different organ systems depending on where the endometriosis implants are found and how they're affecting those organs. So you can see GI and intestinal things like nausea, vomiting, diarrhea, constipation, rectal bleeding, issues with bladder function, having to go all the time, pain when you pee, and then also things that are more difficult to pin down, headaches, joint pain, fatigue, muscle aches, muscle spasm. And it also tends to get grouped with other conditions, other painful conditions that we call chronic overlapping pain conditions. And that's things like chronic migraines, interstitial cystitis, irritable bowel syndrome, um, TMJs, like a jaw condition, fibromyalgia, and a few other conditions that tend to collect in one person. And when that happens, we call it chronic overlapping pain. The thing is that endometriosis has been really difficult to confirm. The gold standard has been surgery. So to look inside and see if there are any implants of endometriosis, remove them, send them off to the pathologist who will look under the microscope and say, yes, this is endometriosis. But for many years, those of us who do this work have been saying that that's not correct, that you can find endometriosis without taking somebody to the operating room. And you can find that by actually listening to what she is saying, as well as doing specialized ultrasounds to look for endometriosis. That's what I have been doing in my office for many years, and doctors before me have also been doing so. And finally, our medical guidelines are catching up to what we have always known to be true, which is that endometriosis can be diagnosed without surgery, and you can see endometriosis on imaging studies. So the most recent guidelines out of Europe, Canada, and then most recently, just this month in the US, have stated that you can diagnose endometriosis in the clinic, in the office. So my patient, if I had seen her after March 1st, when ACOG's guidelines came out, I wouldn't have written presumed endometriosis on her chart. I would have been able to look at her and say, you have endometriosis based off of what you're telling me, what I'm seeing, and what I'm seeing on this ultrasound. We've seen this shift because endometriosis care for everybody, not just Black women, is really delayed. So it takes on average 7 to 11 years for a woman to be diagnosed with endometriosis. And Black women are significantly less likely to receive an early diagnosis compared to white women. And that can be an additional 2 to 3 years of suffering beyond what other women have to suffer. None of this is okay. So the additional 3 years is not okay, but the average of 7 to 11 years also isn't okay. And the more recent guidelines that have come out in the past 4 years are really aimed at shortening this time to diagnosis. That way, women can start treatment that is effective quicker. The real question then is, why is it that Black women are not being diagnosed earlier, and what can be done differently? And when I look at the reasons why Black women aren't being diagnosed, it really breaks down to 5 distinct checkpoints where their needs aren't adequately being addressed. There are several things that have to happen for someone to be recognized as having endometriosis and then get adequate care. And there's lots of opportunities along the way for that just not to happen. So, number one, there's the need to listen. Two is the need to investigate. Three, the need to recognize. Four, the need to refer. And then five is the need to design equitable systems. The first checkpoint, need to listen. And this goes right back to the beginning where endometriosis begins. Women have endometriosis and symptoms of endometriosis really when they are girls. A lot of women will start to have symptoms soon after their first period. So the people that they need to listen to them at that age are their parents, their siblings, their aunties, their grandparents, their teachers, their school nurse. And the issue is that that isn't happening. Girls are more likely to be told that this is just what it's like to be a girl. Welcome to womanhood, where everybody has bad periods. And that thinking, especially that everybody has bad periods, could be because the person saying that has been experiencing bad or painful periods themselves, and they may have something that is undiagnosed and they think that it's normal. And that can especially happen in families because endometriosis can cluster in families. So a mom may be telling her daughter that periods are painful because she has faced painful periods that have never been treated. We also know that just in the wider society, there's a normalization of pain in women, especially pain related to our periods. The other bigger issue is medical professionals. And again, it starts at the beginning because a lot of girls are presenting to their school nurse because they're having to be taken out of the classroom. They're balled over in pain. They're asking for heating pads. They're also being taken to their pediatrician. So those are the kind of the two first medical professionals that they encounter who may or may not recognize that what they are dealing with is endometriosis. And when Black people enter the medical system, especially in the US, we know that they are more likely to be undertreated for their pain. They're less likely to receive pain medication. And when they do receive pain medication, it's less amount. So a lower dose or fewer pills, even for the same pain scores as white counterparts. And some of this has to do with the enduring belief that Black people feel less pain. Those notions have been around for a very long time. They're extremely biased and racist, but they continue to exist, even in studies done within the past 10 years. So in 2015, there was a study done with medical students. So these are people who are doctors now. It was medical students and residents. And they found that 50% of them believed some sort of biological difference exists between Black people. And they marked this is true when they were presented with questions like Black people's skin is thicker than whites. And as bizarre as that sounds, it also translates to real effects in medical care because those same trainees that are believing biological differences between Black people and white people also rated Black people's pain as lower and made less accurate treatment recommendations. Study done in 2019 where they had white participants, so white observers, who had to look at pictures of Black people and white people. They had a more stringent threshold for recognizing pain in a Black person's face than a white person's face, meaning that a Black person may have to look like they are about to, fall out in crippling pain to be understood to have a similar amount of pain as someone who looks mildly who looks like they're in mild discomfort and they're a white person. And when a lot of people hear these things, they think about racism. And it's true, there is a lot of racism and systemic racism and bias, not just in the US, but around the world. But I'm not sure if that explains everything that we're seeing in these types of phenomenon. When I was reading this book by Malcolm Gladwell, it's called Talking to Strangers. He has a part in it where he breaks down the fallacy of transparency. And transparency, and this is a direct quote from his book, he says that transparency is the idea that people's behavior and demeanor, the way they represent themselves on the outside, provides an authentic and reliable window into the way they feel on the inside. And that these are crucial rules that we use to make sense of strangers. When someone we don't know or can't communicate with or don't have the time to understand properly, we believe that we can make sense of them through their behavior and demeanor. In his book, he defines a stranger not as someone that you've never met before or someone that you've never encountered. He refers to a stranger as being somebody from a different social world, someone who exists in a different culture. And the big problem with transparency, so believing that what I'm seeing on their face and their body, or what I am perceiving based off of their face and their body, may not be what's actually going on inside because we are actually really, really bad at reading the expressions and behaviors of other people, especially when they are strangers, and more so as the cultures become more different. So when we're talking about Black people entering a medical system, you have to think about who is observing them and who is perceiving them. And is this someone who is from the same culture? Is this someone who is from the same social world? Or is it someone who is a stranger and is just not interpreting the cues in the same way? Okay, so it looks like these videos are playing. So these are little stock clips of women who are in labor. All of these women could be experiencing the same amount of pain. One of them is kind of displaying the type of pain that we are taught to believe someone displays when they are in labor, as viewed on TV and in movies. And if that is our only conception, then we may misdiagnose the other women as not having the same level of pain or not being about to deliver. And of course, this isn't a presentation about labor and delivery, but I feel as though it translates well talking about endometriosis and the way people may look when they're having an endometriosis flare and going to the emergency room, or when they're showing up in the office complaining of pain. The way someone presents and displays their pain may be different, and that is perceived differently based off of who is observing. And when that person observing is in the power to be able to diagnose and treat, it becomes an issue. Checkpoint number two is the need to investigate. So when someone is listened to and it's understood that they have pain, are they going to be investigated as potentially having endometriosis or are they not? Historically, in the US, Black women are not. Early studies in endometriosis dating to the 30s and 40s really thought that endometriosis was a disease of wealthy white women. So when you see the text and it talks about the Scrooge of the private patient, the text is talking about private patient to mean affluent women, and then they talk about clinic patients or ward patients to mean either Black women or poor white women. And it was really thought that endometriosis was a lifestyle disease that happened to women who had delayed childbearing and were using birth control. And kind of implicit in that theory was that Black women were less civilized and less susceptible to the types of stress that affluent women have that allows them to get endometriosis. It's really a theory that is problematic all around, but it has created this lasting stereotype that endometriosis is rare in Black women. And it's not just Dr. Meggs in 1938. There are lots of studies that were published from the 30s to the 60s which question whether or not Black women get endometriosis and talk about how rare it is for a Black woman to have endometriosis. It was really thought that a certain demographic, so Black and poor, do not have endometriosis. This one article from 1955 was really interesting to me because they talk about how only four Black women in a decade in New Orleans, Louisiana, at this hospital had endometriosis. But then it also says that the note, so the history and physical, couldn't substantiate the diagnosis and that the pathology wasn't recorded. So that means that someone probably just wrote down the word endometriosis, and that's how these four women were found. But then it also makes me think, who else had signs and symptoms of endometriosis and nobody wrote endometriosis? Like, how do you make conclusions when you're saying, even by 1955 standards, that the records are really, really bad? But nevertheless, these notions continued on as history progressed, even in more recent publications through to the 2000s, with the thinking that there is this racial difference in endometriosis and that Black women are significantly less likely to get endometriosis compared to white women. And just for reference, of this textbook, 2016, this was when I was doing my medical training. I did my residency in 2013 to 2017. So these were the types of text that I was reading and I was exposed to. If a physician or a provider doesn't know that a condition exists in a person or a certain population, then it's not on their differential diagnosis. And our differential diagnosis is like our short list of possibilities. So if it's not on that short list, how would they ever get diagnosed with it? And when I say that what was going on through history, so the thought that endometriosis didn't affect women who are Black and poor has continued because today we even see now that the women who are least likely to be diagnosed with endometriosis are Black women at the lowest socioeconomic criteria. The other thing that concerns me about this is this data has been so persistent in our medical literature, and it makes me wonder what data is being used to train our AI models, which are increasingly being used in healthcare. If someone is putting in a patient vignette and they are talking about a Black woman who is presenting with pelvic pain, is that AI model going to be blind to the fact that they've input race? Or is that model going to use that and look through the history and say that it's unlikely that this Black woman has endometriosis? The next checkpoint is failure to recognize. So even if an investigation is done, it may head in the wrong direction. So the idea that Black women didn't get endometriosis was, of course, challenged. That wasn't just accepted at face value by everybody. And one such early study was done by Dr. Donald Chapman in 1976. And he found that 40% of Black women who were found to have endometriosis on laparoscopy were previously misdiagnosed or diagnosed with pelvic inflammatory disease, just like the patient that I had shared with you. And it's really interesting because pelvic inflammatory disease melds really well with another stereotype of Black women being promiscuous and being more likely to get STDs. The bottom line is that the lower diagnosis rates in Black women may reflect issues with diagnostic bias, as well as disparities in access and care, and not actually proof that Black women are less likely to have the disease. The other thing that we have to contend with is Occam's razor, which is a tenet used in many different fields, but most definitely in medicine. And we think about it as being a unifying diagnosis, that the simplest explanation, one diagnosis explaining all findings, is usually best. And that's the case. Is usually it's not, eight different conditions that the patient has suddenly come down with together. It's usually one condition that is having these eight different manifestations. However, this has its limits and it leads to Black women being diagnosed. And that can happen where one diagnosis could explain their symptoms, but they could really be having more than one. And what I'm talking about is fibroids. Black women are more likely to have fibroids. By the age of 50, about 80% of Black women will be found to have a fibroid. And they are very easy to see on ultrasound, whereas endometriosis likes to hide from ultrasound or MRI, fibroids just pop right up. And so when someone is complaining of pain, when they're complaining of pelvic symptoms, and they're ordered a pelvic ultrasound, and someone sees a 4 centimeter fibroid, then the fibroid gets blamed for all of the pelvic symptoms that she is having. But you can have fibroids and you can have endometriosis at the same time, which is why I refer to that as being underdiagnosed. Yes, you have found one cause of the symptoms, but she may have other causes. A more recent study, I believe this was 2021, done in the Boston area, found that 41% of Black women who had been diagnosed with 41% of Black women had been diagnosed with fibroids before they were diagnosed surgically with endometriosis, compared to about 18% of white women. And it's just important to understand, especially with this condition with fibroids, because about 20 to 80% of women who have fibroids have coexisting endometriosis. And the endometriosis gets hidden from view because fibroids are much easier to see and diagnose. Checkpoint number 4 is the need to refer. There is often lots of different referral points that a woman needs to go through when she's presenting with pelvic pain and trying to work her way to specialized care. She may be seeing her GP or PCP and have to get referred to a gynecologist. She may end up seeing a gynecologist who doesn't do surgery or doesn't do endometriosis care. She may need to get referred to someone who can do an ultrasound, because not all gynecologists do their own ultrasound. And there's just lots of opportunities to kind of get lost in the sauce here. What we do know is that minimally invasive surgery, so laparoscopic or robotic, is the gold treatment for endometriosis. However, hospitals that serve a high number of Black women are less likely to offer a minimally invasive surgery. Black women often lack access to high volume surgeons who are trained in complex endometriosis care. And when they aren't able to access that care, then they get trapped. They get trapped in cycles of ineffective pain medications, incomplete surgeries that may just like burn the tops of lesions but leave the rest behind, having to have repeated surgeries, going back and forth to the clinic, going to the ED, and living in continued pain and other symptoms that are affecting their life. We know that Black women are less likely to undergo a minimally invasive surgery and are twice as likely to have open abdominal surgery for gynecologic concerns, including endometriosis. They are also more likely to have complications like longer hospital stays. We know that even when we control for the type of surgery, so Black women having open surgery and white women having open surgery, Black women having laparoscopic endometriosis and white women having laparoscopic endometriosis surgery, they are still more likely to have complications. They are 64 to 71 times at higher odds of having any complication within the first 30 days following surgery. And these can include things like urinary tract injuries, urinary tract infections, or having to come back to the hospital. And then we just come right around full circle where it comes to prescriptions for symptoms and pain medications, also being an area of disparity. There was a really interesting study when they looked at prescription patterns for women with suspected endometriosis and confirmed endometriosis. And of the 28 drugs that they looked at, 17 were significantly less likely to be prescribed to Black women. Unsurprisingly, one of those medications was pain medications, especially for Black women who had not had a surgical diagnosis of endometriosis. So that really just fits with everything else that I was saying about not being heard and not being believed for having pain and having kind of less prescriptions, less number of pills, less dose of prescription pain medications. The other thing that was really interesting was that Black women are also less likely to receive prescriptions for other comorbidities that go along with endometriosis. So less likely to receive medications for things that affect the GI or the bladder, so like the constipation, the diarrhea, the frequent urination, the painful bladder syndrome. Black women are less likely to have that addressed with medications, which indicates that Black women are less likely to have holistic endometriosis treatment. I am a surgeon. I do endometriosis surgery, and I can tell you that endometriosis care does not necessarily stop just with surgery. Oftentimes, even though endometriosis is removed, there are still other issues that need to be addressed, other organs that have been affected by the chronic inflammation. And Black women are less likely to get care that addresses them as a whole. And then we have research gaps. So less than 10% of clinical trial participants in endometriosis research are non-white. And this is important when it comes to medications and treatment, but it also is important when it comes to diagnosis. And here's why. When you have medical societies that are moving to a clinical diagnosis, then it's dependent on the doctor now to decide whether or not this woman has endometriosis. They may be looking at data that says women with endometriosis have these types of complaints or have these types of symptoms. But if the studies aren't being done on Black women, and if Black women are presenting their endometriosis differently, if they're talking about their symptoms in a different way, or if they tend to be more bothered by certain things, and that's not making it into the medical literature, and then doctors are not being educated about it, how are they going to be able to give her the right diagnosis? Right now, you might be thinking, well, maybe I just need to find a Black doctor. But that is also another area of disparity. I was at an endometriosis event earlier this month, and someone was complaining that there are lists of doctors or excision surgeons, and there are no Black doctors on those lists. So that's something that needs to be addressed because there are Black doctors who do endometriosis care. Here are four of us together at an event a couple weeks ago, and there exists more of us both in this country as well as others. I know that seemed like a lot of doom and gloom, but the important thing to know is that you can still get great care. And I really believe that knowing about these challenges and the shortcomings in our medical system helps you to be able to navigate them better. And so I'm not just going to leave you in the doom and gloom. There are things that you can do to be able to move forward confidently. And again, there's a QR code to get the slides. That way you can take this away with you. Moving from needing to be listened to actually being heard. An important thing is being upfront about what you are going through. Um, despite what my accent may have you believe, I am Caribbean. I grew up in a Caribbean house. I live in a Caribbean house. I understand how Caribbean people act when they go to the doctors, and you do not like to tell the doctor what you are going through. But this is the time to be really upfront about what you are feeling. Don't minimize it. Definitely don't say that you are okay because you're not okay. You are having these symptoms, and that's why you're going to the doctor's office. So say clearly what your pain is like, how often you're having it, what it keeps you from doing. Something like, my pain is severe enough that I miss work, I cancel plans, I can't function normally. And then don't normalize severe symptoms as just being part of being a woman, because periods are not supposed to be painful. Some people, and this is normal, just have like a little bit of mild discomfort or maybe take a Midol or Panadol every now and again. That's normal. Having severe pain that's preventing you from participating in life is not normal. And then keep records. Sometimes we don't even realize how bad we're feeling until we write it down. I love when people come to my office and I ask them about their symptoms and they pull out their phone app and they're able to tell me exactly when their last period was, when they, last vomited, how often they are feeling ovulation pain, that sort of thing. And when you actually write down your symptoms and look back, you might be surprised. You might look back and say, "Oh my gosh, I haven't had a bowel movement in 4 days, and that's not normal." The other thing that you can do is bring a friend or a support person. Sometimes it can be difficult to remember all the things that you want to ask, or you may be shy or afraid to ask certain things. And having somebody else that can be there for you can be really helpful. It can be very overwhelming to go and see the doctor, and they may be throwing a lot of information at you. And when that starts to happen, you're thinking about, oh my gosh, I need surgery. I have to take care of this at home. How am I going to get time off? Meanwhile, the doctor is still talking and you're missing all of that. But if you have a support person, then that can be really helpful just to have another set of ears. And then going from needing to investigate to actually having endometriosis as a possibility. It's okay to say plainly that I'm concerned I could have endometriosis because I have severe period pain or because I have this bloating and I have really painful bowel movements, whatever it is that you're feeling. And it's important to actually say the words. Don't try to beat around the bush and make them play Sherlock Holmes. If you think you have endometriosis, it's okay to say the word endometriosis because, as we discussed, it may not be on their differential and it may not be top of mind. So, by you saying that, then it gets put in their mind and they can consider that as they are looking at you as a whole. Also mention your family history because endometriosis can run in families. So you can point out that my mom, sister, and aunt all had endometriosis and I'm having similar symptoms. And that can clue your doctor into thinking, oh, maybe this is endometriosis because everybody in her family has endometriosis. Also, don't let a normal test end things. If you're ordered an ultrasound and then you find out that the ultrasound is normal, you got to go back to the doctor because you're still having the issue. When you don't go back, they think that you're no longer having an issue. Even though something isn't shown on an ultrasound or an MRI or a CT scan, doesn't mean that you aren't having that concern. Next, to move from the need to be recognized to having the correct diagnosis, you can always ask if more than one diagnosis could be true. You can say something like, I know I have fibroids, but could I also have endometriosis? And then similar to following back, if you have like an imaging study that is normal, also follow back up if treatment isn't working. So if they say, oh, I think you have a pelvic infection, and they give you antibiotics, and you take your course of antibiotics, and a month later, 2 months later, you're still having the same symptoms, you can't just like write that off and then decide to live the rest of your life having these issues. You have to go back to the doctor because they think that if you do not come back, then you're just living the good life. So you have to return and say, I took the medication, it didn't help. Now what can we do? And then hopefully the next step gets you closer to what you really need to get taken care of. And then, so connect the full symptom pattern together. And so that is kind of laying out everything that you're feeling because sometimes we think that things aren't related, therefore we don't bring them up. And it's not for you to know whether or not it's related. That's for your doctor or your provider to figure out and put those pieces together. But if you don't tell them all of these things that may or may not go together, then they may miss the clues of a diagnosis. And then to go from needing to refer to finding the right help, you can do your own research for referrals. You may live in a country where it takes a long time to see your primary care doctor to get a referral to a gynecologist. It's helpful if you already know the gynecologist that you want to see, because then you can just kind of lay out these three options. I looked into these three. Would you recommend me seeing any one of these? That way, who you're going to be sent to is someone that you handpicked who already knows about the diagnosis you're concerned about, let's say endometriosis. The next is to ask for specialist care if you need it. So you can say, can you refer me to someone who specializes in chronic pelvic pain? And then you can ask physicians about their experience. And as a surgeon, I can say this is one of the questions that is the most important, but I am asked the least often, and that's about experience. So asking them how often they perform this surgery or how often they perform it this month, or do you specialize in this type of care? Have you seen a case like mine before? Do you usually manage patients with endometriosis yourself, or do you refer them to a specialist? And then lastly, for the need for equitable systems and turning that to looking beyond the individual visit. Things that you can do to help create a better system for everybody is joining patient and advocacy groups. It really helps to kind of build that community. That way you feel less isolated and you learn from other people's experiences. They can also be really helpful to teach you the language and the words to use to be able to advocate for yourself. Number two is understanding the need for holistic care. Again, one surgery or medication may not address everything, and the effects of endometriosis can involve the bowel, the bladder, the pelvic floor, your muscles, your nervous system, and those also need to be addressed. And then lastly is turning your personal experience into collective change, meaning sharing your stories, especially in the Caribbean. We don't talk about these types of things. And talking about it to your loved ones may help you to find out there's other people in your family who have been suffering with the same thing. And then also helps the next generation to understand that these things aren't normal and how to get care. It helps to build support, awareness, push for better education, faster referral pathways, and just overall getting more equitable access to expert care. Well, thank you very much. I would love to hear what questions you guys have.
Thank you so much, Dr. Smalley. We really, really appreciate that. Um, Odelia, are you going to be reading the questions from the chat first?
No,
Or the questions we had from before, I think.
yeah, Kimet has those questions, so she'll be
Yes.
reading those questions.
Fantastic. Thank you.
Hi, good night, everyone. And thank you so much, Dr. Smalley, for that insightful and powerful session. Lots of gems you dropped there. So I'm going to start with the comments because we have a lot of persons, sharing the love. So Heather first says, Dr. Smalley is the absolute best. And indeed, we see why she says this, right? Someone asked, wait. Can you have TMJ and endometriosis?
Absolutely. Yes. Both of those are conditions in that cluster of chronic overlapping pain conditions. And it's not that endometriosis causes TMJ, but they tend to collect in people, as I'd like to say. Some people are unfortunate enough to collect multiple pain conditions, and it may have to do with inflammation.
Okay, thank you for that. So what you're saying is like they could pretty much coexist, right? Yeah. So
Exactly.
comorbidities there. All right. Thank you for that. And someone says they've seen a lot as a medical social worker, and we could imagine, right?
Mhm.
Just a few other comments coming in. Someone says, I wasn't even diagnosed with PID. They just told me that I had bad periods when I was quite literally incapacitated every month. So I think that's something, a lot of us could relate to, right?
Absolutely. Absolutely. And then that just becomes your normal.
Yeah, it's normalized. So there's a lot of chat too about the ages that persons were diagnosed and, how long it took between having the first set of symptoms and being formally diagnosed, right?
Mhm.
Um,
Absolutely. And it's usually too long.
Kimet?
Someone says, I've been complaining since 16. I've had multiple doctors disregard me and I've brought up endometriosis. It wasn't until I was 22 that someone listened, but by then,
I think you muted yourself.
Kimet?
sorry about that. I was having a bit of distraction there. My niece, like she's trying to listen in. Yes,
It sounded like someone had was having symptoms from the time they were 16 and even brought up that it like, could this be endometriosis? And nobody did anything.
listen. Yeah.
That does happen. Even when you say, I think I have endometriosis, or can you look and see if I have endometriosis, that may not happen. And if it feels like you're doing all of the things and you're not being listened to, then you have to find a new doctor. Mhm.
Definitely. And she ended her comment by saying, it wasn't until I was 22 that someone listened, but by then the endo quite literally ruined my body.
Yeah, that's a real consequence of these delays.
Met, are you back? Okay. So I'll just move on to the next comment. Stephanie. Hi, Stephanie. She says the next generation needs us to speak up.
Exactly.
Okay.
Tell them what you're going through.
Yeah. Heather had to leave, but she said that your presentation was outstanding. And thank you so much. We have a question. Can you clarify how they are now able to diagnose endometriosis without surgery? And also, more generally, are there endometriosis specialists in the Eastern Caribbean?
Mm. Um, the second part's easier for me to answer. I do not know. I don't know where endometriosis specialists are in the Caribbean in general, not just the Eastern Caribbean. Hopefully somebody else from the organization may know. And in terms of diagnosing endometriosis clinically, um, how it's being done now is based off of symptoms. And for ACOG, that's who I tend to follow because I'm in the US, although I do look at guidelines from around the world because I like to know. They have a list of signs and symptoms that are suggestive of endometriosis. And I believe it says when someone is presenting with one or more of the following, then you should be suspicious that they have endometriosis. And these are symptoms that are either coming like cyclically, like how a period comes, or even not, like once a month in that sort of pattern. But things like chronic pelvic pain, painful periods, pain with sex, pain when you pee, pain with bowel movements, infertility. And then they also talk about things outside of the pelvis, like bloating, diarrhea, constipation, nausea with pelvic pain, nausea with painful periods, especially in adolescents, rectal bleeding, shoulder pain, pneumothorax, so that's lung collapse, hemothorax, that's blood in your chest cavity, sciatic nerve pain, surgical scar swelling or mass fatigue. And then in terms of what we do with ultrasound, it's what we call a dynamic ultrasound. And it can be just transvaginal or a combination of transvaginal and over the belly. And it does more than just, measure and tell you whether or not there's a uterus and how big ovaries are, but it's really looking to see how your ovaries move. Are they stuck to the side of your pelvis? Are they stuck to your uterus? Do they seem like they're in a strange location? What's the shape of your uterus? Is there pain when we touch certain areas with the ultrasound probe? What's the texture of the uterus like? Does it seem like the bowel is stuck to the back of the uterus, or are those moving independently of themselves? This type of ultrasound in the US is really starting to catch steam, but it's been done much more often and more thoroughly actually in other countries, especially Italy and Brazil. Brazil has really made a lot of headways in being able to diagnose endometriosis by ultrasound, and they do very detailed ultrasound scans that usually take 40 to 60 minutes. They sometimes do like a whole bowel prep, the ultrasound starting from the kidneys, working all the way down.
Um, to answer the second part of the question, which you weren't sure about, we do have some surgeons that have seen endometriosis during their training, whether they were in the UK or other places abroad. Um, a big, we have other hurdles in the West Indies. So they may have seen and been trained in it, but their volume, their surgical volume is very low because they have the opportunity, they only have a few opportunities to perform endometriosis surgeries throughout the year. And then the next hurdle is most of the islands don't have the correct equipment to do the job properly. Most of these procedures are done open. They don't, a lot of the islands don't have the ability to take photos or video during the surgery. So the only record you have is what's in their written report. So there are quite a few challenges towards getting surgery within the Caribbean.
Mm-hmm. These are tough things.
Yeah, I mean,
Yeah.
and then also only a hand. What, Odelia, maybe you could tell me. Do you know how many islands have blood banks? I think maybe only a
Everybody,
handful.
we all have blood banks, but the question is, um, not the question. The issue is that when you need the blood, you have to put out a call. You have to call your friends, you have to get your relatives. So it's not that there's usually an issue with blood being in the blood bank.
Hmm.
Um, and that's across most of the islands. Um,
Mm-hmm.
so you would often see flyers going up, so and so is in the hospital, needs blood. My last surgery, I needed to get 6 donors. I was told I needed 6 donors. And the surgery before that, I needed to get 3 donors.
That was
So
before you that was known before you went into surgery?
Before you go into surgery, you have to have your donors already donated the blood.
Hmm.
Yeah. So I
That's
I
so hard.
yeah, I was having a side conversation with Alyssa and Kimet while you were speaking, and I was telling them, I'm listening to you and I want to cry because as a Black woman in the Caribbean, I think our hurdles and our experiences are personally for me are even worse than Black women in other countries who have access. Our
Hmm.
lack of access makes things a lot worse. And
Hmm.
here, when you were talking about don't be afraid to ask your doctor questions or say this is your experience, it can be so difficult to say that
Hmm.
because we still have doctors on this pedestal here. And
Yes.
doctors tend to have, I call it a quote unquote God complex. And
Hmm.
so when you ask questions, it's as if, how dare you? I've actually had doctors tell me, I'm telling you what is wrong with you. Don't ask me any more questions.
Mm-hmm. And then that makes you afraid to ask a question to a different doctor
Hmm.
ever.
Yeah. And so your experience as a woman here it's challenging. Um, I saw myself in all of what you were saying. I saw the woman in my family. I saw the woman that we serve with our association as you were speaking. And I'm just there thinking to myself, where do we go from here? Because access is the biggest issue that we have. That and being diagnosed in the first place.
Exactly. Exactly. Those are the two biggest hurdles. Finding out why you're having these symptoms, getting that diagnosed correctly, and then getting it treated properly.
Mhm. Yes.
It's difficult to get the proper treatment here in the US, where there's like a lot of endometriosis excision surgeons compared to pretty much anywhere else in the world,
Mhm.
more than like per capita in Canada and in Europe. So it is infinitely more challenging when you do not have an excision specialist where you live.
A question. How do you know it's time to get an operation due to endometriosis affecting your other organs?
Yeah. So I didn't talk a whole lot about the like excision surgery or endometriosis surgery. The thing about endometriosis is that sometimes it gets worse. So sometimes it progresses to more advanced stages. Sometimes it does more damage to organs or tissues. Sometimes it affects fertility, but sometimes it doesn't. And we don't know who is going to progress from stage 1 to stage 4 and who's just going to stay the same. So I've operated on women who are in their early 60s who have stage 1 endometriosis. It just never got worse. I've also operated on teenagers who have stage 4 endometriosis. And if the big thing that we are missing is some way of knowing whose disease is going to progress and get worse and whose isn't. Because if we had that test, you could get that test when you're a teenager and you could know, okay, it's going to be stage 1 endometriosis. And if you're okay managing your symptoms with medication, that may be all that you need. Or you may get a test and say, you have a really aggressive form, and this is something that needs to be taken care of more urgently. We don't have that test. I wish we did. So without that, what I always remind my patients is that I don't know whether or not your disease is going to get worse. I can start you on medications which help to control the symptoms, but we don't have any medications that stop endometriosis from growing. And we don't have any medications that stop endometriosis from damaging tissue. So even if you're feeling better, endometriosis can still be getting worse. We know that when you have a proper endometriosis excision, your chance of having another surgery is really low. So usually less than 15%, and in the best hands, less than 10%. So for a lot of people, it's just one surgery. So it's whenever is best for you to have that one surgery. The sooner the better, because we don't know whose disease is going to progress. But the most important thing when thinking about surgery is who is going to do that first surgery, because the first surgery is the most important. And that's the best opportunity to be able to remove all of the endometriosis and really kind of change the trajectory of a life.
Thank you. Are there blood tests that you tend to run in addition to the imaging that give you as an endo specialist information about the patient? And thank you for your presentation, Dr. Smalley. Your IG videos are helpful.
Thank you for following me on Instagram. Yes. Um, there can be other things that I order, not for diagnosing endometriosis. For me, that is just clinical exam and ultrasound, and that's enough to move forward to the operating room. But I may order lab tests for other reasons. One that is more particular to endometriosis is if there are cysts on the ovary, so endometriomas that are going to be removed, because we know that endometriosis cysts on ovaries lowers the number of eggs and the quality of eggs that are there. But we also know that removing those cysts also lowers the number of eggs that are there. So it can do it's really important when it comes to thinking about fertility and planning for future children, if that's what she wants to do. So I may order a test. So this would be like an AMH or anti-Müllerian hormone to try to get an idea for how many healthy eggs she currently has. And that can help to know whether or not she should see a fertility doctor before doing her endometriosis surgery to remove eggs and freeze them.
Thank you.
You're welcome.
Thank you. You read my mind. Literally, I was saying AMH in my brain while you were talking.
Yes, yes.
Thank you so much.
And that is, I didn't talk about that today, but that's another issue that comes up with disparities for care. So Black women are more likely to have an ovary removed, more likely to have organs removed in general, but more likely to have one or both ovaries removed when somebody else may just have a cyst removed. They are less likely to be referred to a fertility specialist to try to preserve their fertility than other people. And sometimes that's because a doctor may believe certain things about their finances and access. And I believe that I don't know about people's finances and access, so I counsel all people the same and lay out these options for them. I don't know what they may do with that information. They might sell a car and freeze their eggs if that's important to them, but they can't make that decision if they don't know it's a possibility.
Yeah. My first surgery, I woke up and I was missing an ovary. So yeah. We have a lot more comments in the chat. So somebody said I was 31 when I finally got the care I needed. I only suspected I did when my friend who had endo, more severe than me, showed me the way, and I took a serious look at my symptoms. She helped me advocate for myself to my doctors who took me seriously and then helped my younger cousin get diagnosed. At my worst, endo almost took my mobility, and it was caught in time where I avoided becoming paralyzed.
Yes, yes, really severe symptoms. That's another one that people don't necessarily pair with endometriosis. Like the pain in the legs, the thigh pain, the pain going down their knees, down to their feet. Was also talking about the importance of sharing your stories. So, if their friend hadn't shared her struggles with endometriosis, then she wouldn't have been diagnosed. And if she hadn't shared her story, then her cousins and family members wouldn't have gotten the care that they need. So it's important as women that we talk about these issues.
Yes. Another comment, I collapsed in my FD in front of my lieutenant. They thought I had cancer because they
Mhm.
found a 5 pound, 18 centimeter endometrioma, along with several others upon surgery. I had terrible pain since menses started. How can we get doctors to do more extensive pathology as a standard for endo on cysts and masses? I think it can be found earlier if they are more proactive.
Hmm. Yes. I think that's why there's been this push with medical societies for earlier diagnosis. So more women are going to get the label of endometriosis, which by itself doesn't necessarily move the needle, but I think the women with endometriosis will. It's going to be like, well, I have this endometriosis. Now what? Now what do I do?
Mhm.
And pathology is a whole nother thing. So when we remove things and send them off to pathology, off to the lab, they have their particular criteria and way of looking at things. And they also have to undergo particular training to be able to understand pathology coming from different parts of the body. Everybody through that whole line needs to be educated better about endometriosis. That way, they have a correct diagnosis on pathology. That way, when someone goes for their ultrasound or MRI, the sonographer can identify it. The radiologist knows what it looks like. There's just so many opportunities for improvement.
Crazily enough, I wasn't aware you could have endometriosis anywhere in your body until I, in fact, had a hemothorax, and the endosurgeon I seen brought up having bowel endo, which again I didn't know was a thing.
Mm. That's because for some reason endometriosis has been um, it has been called or situated as a gynecologic condition. But, by definition, it is outside the uterus. It is someplace not on the uterus. And we don't have many other gynecologic organs. That's just our fallopian tubes and ovaries. So it is a whole lot of places that is not gynecologic. One of the other things that has changed over the past couple years is our medical societies and our journal articles have moved from calling endometriosis just a gynecologic condition. So in this new ACOG guideline that came out at the beginning of this month, I'll read you just the first sentence or so. It now says that endometriosis is a chronic inflammatory estrogen-dependent disorder defined by the presence of lesions of endometrial-like tissue outside of the uterus. So it's no longer calling it a gynecologic condition in recognition of the fact that it affects so many things, such as the bowel, such as the chest cavity. My goodness, I can't imagine what it feels like and how scary it is to come down with the hemothorax and find yourself in the emergency room and hospital trying to get treatment for that. But that is severe endometriosis.
100%.
Someone who asked a question earlier that you answered said they have a follow-up question for you. If endometriosis is removed during surgery, is it likely to return even in mild form, and what should we consider in terms of management?
That's a really good question. And there are, so most endometriosis surgeons wouldn't call their endometriosis surgery a cure in recognition that some number of women will either continue to have symptoms or redevelop symptoms. And the question is that because new endometriosis has grown or because endometriosis was left behind? In a lot of it, we believe it's because endometriosis was left behind.
Mhm.
Even like the best surgeons and the ones that I've trained under are world renowned. They are humble enough to admit that they can miss endometriosis. It can be like a little millimeter tinier than a pimple thing that needs to be removed. That's what it looks like a lot of the time in teenagers, and it's very easy to miss. So someone may go in and do a multi-hour surgery, remove a ton of endometriosis, but if they miss that little millimeter area, then 5, 6 years down the line, that area may grow more and cause more symptoms. The question of should you have surgery again really depends a lot on what you're going through, how much surgery helped you the first time, whether or not you want to undergo it. Uh, but there is a possibility of needing another procedure or wanting to be on medications. I didn't talk about adenomyosis. Really, adenomyosis is like endometriosis's sister. So that's where endometrium-like tissue is growing in the muscle of the uterus. And that's one of the most common reasons why someone may seek another surgery because they're having pain in their uterus from adenomyosis.
Mhm.
So there can be a number of things, unfortunately, that can happen.
Okay, thank you. And the person with the hemothorax has just commented again. She said, I was scared but significantly annoyed, especially because I had to get 3 long surgeries and a partial bowel resection. To be honest, that year I had a chest tube every month on my period.
Yeah.
Wow.
For me, with because I was a thoracic case as well. I very fortunately never had any lung collapses. But I did have like really significant shortness of breath, and I had quite a lot of symptoms, and they were all attributed to other things that I didn't actually have. And it took them a really long time for people to be like, yeah, I guess you do have thoracic endo. And then I had a couple other smaller surgeries that I had to deal with earlier in the year before I could go see Dr. Cinervo. And every time I would have a procedure and doctors would hear that there was a girl in the hospital with thoracic endometriosis, you would see them like kind of hanging out by the door, like trying to pretend like they were being sneaky to look at me. And I'm like, I see you. You can come in if you want to ask me questions. It's okay. Like I was some kind of a zoo, I don't know,
Yep.
exhibition.
100%, yes. And thank you for allowing them to talk to you. I always tell people that it's never fun being the exciting patient in the clinic or the hospital. It's never fun being that person where the doctor's like, hang on, there's a medical student. Is it okay if I let them come in and do an exam? Because you know that means that you have something rare going on.
Yeah.
Yeah.
Um, but thank you for bearing with them because that is something that they have now seen and had an opportunity to understand a little
Mhm.
bit more. And I definitely can see that happening. I'm
Yeah.
sure everyone wanted to know more, and we want them to know more. So what we teach medical students and residents is to like read and learn around your cases. So when they hear about thoracic endometriosis, they kind of want to put a face to it. They want to ask those questions to kind of build those blocks in their mind. And even if I'm guessing these were not gynecologists, so maybe internal medicine or general surgery or thoracic surgery or a pulmonologist, they can now add that to their differential, their short list of possibilities when they have someone coming in with the types of symptoms that you were talking about.
Yeah. I being in the Caribbean, I have 2 questions sort of going in my head. The first one is about um families. I have read that if you have a first degree relative with endo, you are more likely, or your risk is increased of you also having endo. And from my own family experience, um, I was after all of this drama with getting diagnosed, I eventually ended up with 4 diagnoses: endo, adenopicus, and fibroids. And I knew my mom had fibroids, but when I saw that part about it being maybe genetic or running in families, she said to me, you know, I have my pathology report from my hysterectomy.
Oh,
You want to read it? And I'm reading the pathology report and I see, in addition to the fibroids, adenomyosis is on her pathology report. So I said to her, did the doctor ever tell you you had adenomyosis? And she's like, what's that?
Mhm.
And so after her surgery, and she gets her pathology report a few weeks later, they give her the report and send her home. And nothing was ever explained to her. And I think for my mother and that generation of my family, a lot of them don't have diagnoses, but they have all of the symptoms. And so now myself and so many of my cousins are being diagnosed. And now we're looking at our mothers who we know had these same symptoms. And now we are all here like, could it be?
Mhm.
So, my question would be, is there like a genetic link? Is there, something about running in families?
Mhm.
Um, and should we be concerned about like if we have kids, right? What should we be
Oh,
looking?
those are good questions. So yes, there is a familial link. I believe it's that if you have a first degree relative, so like a sister or a mom, you're 12 times more likely to have endometriosis than someone who does not have a first degree relative. And that number may be higher because that's just, first degree relatives that we are aware of. We think that there may be a genetic link, yes, for endometriosis, adenomyosis, as well as fibroids, as well as some, common environmental factors. You're kind of growing up in the same household, in the same environment as your siblings and your parents. When it comes to what do we do about our children? Because we may have young children or there may be parents on here right now. You can be your kid's advocate. So you know what the symptoms are. If you notice that she is having a lot of pain on her period, she doesn't want to get out of bed, she's missing school, she's not going to soccer practice or that sort of thing, then you now know these signs to be able to advocate for her and take her to a doctor who will help. That could be a pediatrician. We have a newer subspecialty now called peds and adolescent gynecology. So these are people that did training after OBGYN to work primarily with kids and young people who have gynecologic issues. That's another possibility. But having someone who knows the symptoms is one of the best things out there because now you have a possibility to bring a 15-year-old or a 16-year-old to the doctor to have endometriosis excised and potentially change the pathway of their life and change what the next 20 years of her life could look like.
Yeah, thank you. And then my second question is, as somebody from the Caribbean, we believe in our bush. And bush fixes everything. Herbs fix everything. And when we don't get that answer from the doctors or we're not getting that pain relief, because often we're just given paracetamol or ibuprofen and
Mhm.
sent home with that, and that does nothing. Um,
Mhm.
I'm not sure if there's any research on our various bushes and
Mhm.
herbs that we,
You know the answer.
Uh, because
No, there's no research. Could it help? Maybe. If it helps with symptoms and makes you feel better and doesn't seem to be dangerous, continue. I'm drinking tea right now. I was serious about the Caribbeanness.
So, out of my own personal curiosity, you said you were West Indian, but you did not say where you're from.
I did not. Actually, my mom is on here too. We are Bajan, and my
Oh,
husband is Vinci.
okay. I didn't realize. Okay, I see there are a few we got a few Bajans in the audience. I noticed their names earlier.
Barbados in the house.
Yes.
I Stephanie. Okay. Oh, the person was talking about the hemothorax. She says
Mhm.
her mom was her link, but she wasn't aware because it wasn't as severe. So she actually got diagnosed after me. Thankfully, my mom was my advocate because my problem was throughout adolescence. And in terms of herbs, she swears by calendula and ginger.
Mm-hmm. Love some ginger.
I'm a ginger girly too.
And again, we see our mothers. It, again, it's the research. We need research because often when we do a lot of sharing about different research on the different conditions, and we have been preparing for Adenomyosis Awareness Month and
Mhm.
finding articles that are from the Caribbean. I've been pulling my hair out. Um, we shared today on thoracic endo in the Caribbean. We found a study from Martinique, and they had a very high incidence of thoracic endo. And so the people were asking in the comments, basically, and even in our messages, eh, is it because, is it in Black women that there's a high incidence of thoracic endo? Is it something in the Caribbean? I think somebody even asked if it was the food. Um,
If it was the barometric pressure,
if it
people
was
were
the
asking
barometric pressure.
all different kinds of things people were asking, yeah.
Interesting. Those are in, I have no idea. I didn't know that was happening in Martinique. Um, but this is why it's so important that Black women participate in research. Especially in the US, there's a reluctance for Black people to participate in research because of the history of being taken advantage of within like the medical research society. And it's a very founded fear about being like a test subject or just having things tested on you that aren't for your benefit. But it is important that we participate in ethical research, obviously. That way these things can be studied.
Yeah.
I always anytime a doctor gives me an opportunity to participate in research, I participate in it because it can only help us. But what you said is 100% true. There's so much history here of the government taking advantage of us. And so folks are incredibly reluctant to participate in research studies. So
Understandably so.
it's a difficult thing, and I don't know how we move forward to bridge that gap. How trust can be regained.
Mhm.
Yeah. And then we have, okay, Liz, I guess you can answer that question in the comment, but we have some of our fellow Endo sisters from Trinidad here, and one of them said she's also been diagnosed with long endo.
Mhm.
I I find
Interesting.
even just hearing
You're
this,
making me wonder if there's a higher incidence in the Caribbean.
yeah, I'm just about to say, from this small gathering here, we have
I
so many.
mean, most of the advocates I work with in the States, all the majority of the Black advocates I work with all have thoracic, and only one of them isn't Caribbean. So
Wow.
yeah,
That's
so yeah, I
interesting.
we're and
Mm.
something else that has been interesting, specifically with thoracic endometriosis, a lot of surgeons have reported, there's no studies, but a lot of surgeons have reported that we present slightly different. We seem to have an accumulation of fluids because you know how endo lesions excrete their own fluids. For some
Mhm.
reason, when we have thoracic endometriosis, we collect a lot more of that fluid. So like for my surgery, I will only speak about my surgery. I won't speak about anyone else's surgery. They did pump a lot of stuff out, and that was a big cause of my shortness of breath. There was just so much fluid. Um, so you know, we're not sure why we present differently, and perhaps maybe because we present differently, they're catching our thoracic endometriosis more. I don't know.
Maybe,
That a possibility? Like I don't know. We don't
maybe.
know. There's no way for us to know. We can only speculate. We
Yeah.
can only
And that's like that goes back to that issue where only 10% of endometriosis research participants are non-white.
hmm
And if you just have this small percentage, so that's for Black, Hispanic, Asian, South Asian, who may be presenting in these different ways, and it may not be recognized as well because people like me who read these studies aren't getting those nuances.
hmm
Oh, Arlene says there are 3 known cases in Trinidad. And I'm just thinking about how many more there could be who are walking around undiagnosed.
Undiagnosed.
Exactly. Because
Undiagnosed.
sometimes young women have pneumothorax and it's taken care of, but the connection to
Yeah.
endometriosis is not
Isn't
there.
made. Yeah.
Mm-hmm. Okay. And will be our last question. Oh, Stephanie says she uses the Fendo app, which allows her to track her symptoms and participate in research. So if anybody was looking for an easier way to be part of research, Stephanie's recommending the Fendo app. So her question to you is, Dr. Small-Layne, have you observed a higher incidence of endo or adeno in Black patients, especially since we have a higher incidence of fibroids?
Hmm. It's hard for me to say because I have such a biased sample. People
Mhm.
kind of self-select to come and see me. So where I live in Washington, D.C., and I've worked in Washington, D.C. and Maryland, and it has disproportionately high number of Black women here. So about 50 to 60% of people just in the general population. And so of the people that I treat in my office, right now it's probably like 75 to 80% Black women. And I actually came to endometriosis from fibroids. I like to tell people that I came in through the back door. I was very interested in fibroids. I have a history of fibroids, as you heard about. And I moved out here because I wanted to, cure the DC area of fibroids. And in doing those surgeries, I found that a lot of my patients have endometriosis, and that's not something that I learned in my residency or my first fellowship, that there is this high co-occurrence of fibroids and endometriosis. And that pushed me to learn and want to do more endometriosis surgery. And one of the ways that we continue to advance our skills after training is watching other surgeons and watching other surgical videos and reading articles. But when I was watching other surgical videos and going to conferences, it was all these like little itty bitty uteruses, and it was very easy to see all these different things in the pelvis. And like, that's not my patient, because their uterus is huge, because they have adenomyosis and they have fibroids. How do I work around someone with fibroids and endometriosis to get it all out? How do I deal with fibroids and endometriosis at the same time? Which is how I got interested in doing more endometriosis care and understanding that connection between endometriosis and fibroids. And then that landed me into a fellowship at the Center for Endometriosis Care, because like, I want to go where they are doing the most endometriosis, the most thoracic cases possibly in the world, and just get all the experience that I can at removing endometriosis to be able to apply it to my population of patients who are coming to me with both endometriosis and fibroids. So it's a very long-winded non-answer to your question about whether or not I see a higher incidence of patient or like as Black women with fibroids and endometriosis. It's hard to say because that's primarily what I take care of.
That makes a lot of sense. Thank
Yeah.
you, everyone, so much for your wonderful questions. And thank you, Doctor, for coming to speak to our group. We hope to have you again soon. We have quite a few pans on the fire, and we will continue that
Right.
conversation later. Please keep an eye out for our calendar for April for Adenomyosis Awareness Month. That's coming up just around the corner. And if you're not following us already, please follow us at she.is.lotus on Instagram. We have a lot more endometriosis facts to share with you as we're closing out March. And thank you, everyone. Thank you so much for joining us both here and on Facebook. We appreciate you so much, and please have a blessed evening.
Thank you,
Thank you for
Doctor.
having me.
Thank you for accepting our invitation. We appreciate it.
Absolutely.
All right. Good night, everybody.